Hello again from San Diego. I'm Jason Jacobson from Westchester Medical Center, and I'll be the host for another episode of Heart Rhythm Society's The Lead, brought to you by the Digital Education Committee, live from HRS 2025. This episode will be discussing another one of the late-breaking clinical trials just presented today, Saturday, April 26. Brugada syndrome ablation for the prevention of ventricular fibrillation episodes, the BRAVE trial by non-Manian colleagues, to be published in Heart Rhythm. Today I'm joined by two expert discussants, Marmar Vaseghi from UCLA and Mayank Sardana from the Mayo Clinic. Thank you both for joining me.
Thank you for having us.
So, Marmar, could you please summarize this interesting trial for us?
Okay, so briefly, this was a multicenter, randomized, non-blinded, non-sham controlled trial where patients that had Brugada syndrome, defined as either having the Brugada type 1 ECG or having, Brugada pattern with agmaline infusion, as well as symptoms, so either a prior history of cardiac arrest or syncope suggestive of arrhythmogenic or even, agonal breathing, as defined by all of our HRS, EHRA, FHRS guidelines. We're basically randomized to either having an epicardial ablation, or an ablation procedure, I should say, for their VF, or to having nothing. And they were all, and one of the other inclusion criteria was just having an ICD. So this wasn't a trial that involved medications. So in terms of results, though, just to kind of briefly summarize, there were a total of 67 patients, I want to say, that were enrolled, 15 that chose not to be included in the study or decided not to participate in randomization. That left about 27 in the ablation arm and 25 in the control arm. Of the 27 that were in the ablation arm, 2 withdrew their consent. So at the end of the day, we had basically 25 patients in the ablation arm and 25 patients in the control arm. Of those 25 patients in the ablation arm, 5 had VF episodes as documented on their ICDs at about 3 years of follow-up, whereas 13 patients had VF episodes or VTVF episodes as documented by their ICDs, suggesting that there was significant benefit, and in the study, about potentially an 75 to 80% reduction in the hazard ratio of having an epicardial ablation procedure.
Great. Thank you so much for that summary. And Mayank, what do you see as the limitations and applications of this trial?
I'll start off with that. I've been waiting for the results for a while, and as you know, the trial was interrupted because of COVID. Right. The BRAVE registry was published a while ago before that, so we've been waiting for the results of this trial. I think one of the most important limitation which we have to think about is what is the patient population here, right? So we don't want to take it as everybody with Brugada needs an ablation, right? So this is a patient population based in Thailand where the disease tends to be very severe. They have nearly, I think, 3 out of 4 had ICD shocks within the last 6 months. So that further signifies how severe the disease is in these patients. And nearly 30% had early repolarization pattern on their EKG, which is again a very high risk marker in Brugada syndrome patient. So that population, how does that translate to rest of the world? I think that would be something to be seen. I don't want to say that ablation has no role, but it's a limited. It has a limited role based on this trial. It's a highly effective therapy. This is what that trial has shown. But whether that translates into clinical practice, to what level that translates into clinical practice, for example, in US, where the disease is mostly benign, if you were to ask me in my clinical practice and other databases which have been published, we mostly see asymptomatic Brugada pattern or patients who presented with syncope. And if you look at the inclusion, I think for this trial, only 5% of the patient had, or 10% of the patients had syncope as their inclusion. The rest of them had VFib or sudden cardiac arrest. So I think it has a role based on this trial, and this is a strong trial to suggest that signal from the ablation. But I think we have to recognize that how generalizable this is to the rest of the world. Number 2, I think is important, as you mentioned, is there's no real control group here in terms of medications, right? So we know that quinidine is such an effective medication for Brugada, and the logic here was that quinidine is not available in most of the world, right? So that's, or a lot of parts of the world it's not available, including in US it's difficult to get, right?
Yeah.
So whether ablation is better than quinidine, or is it incremental benefit of ablation, is it worth it beyond quinidine? I think that is something we don't get from this data, right? So that would be one other limitation, I feel like, because we have several patients who have done really well on quinidine and after the index event, and then have never required an ablation beyond that. So that would be the other big limitation I feel like we have from this trial. And then another aspect from the ablation side of things, the approach which they use is use of edge-milling. So when you define the VFib substrate, or how Dr. Nadamani defines the VFib substrate, it's based on, like, you have a baseline substrate in epicardium, then you give edge-milling to expand that area of abnormal area, I should just say here. We won't go into repolarization here, but that is your substrate which is ablated. So in US we only have procainamide or flecainide. So if, at least anecdotally, it hasn't been published, but if you compare procainamide to edge-milling is such a potent blocker of sodium channel, so you'll have a larger area to ablate. So you're ablating a lot, whether that translates with procainamide or not, because procainamide is going to give you a much shorter area, a smaller area. So the results might be less effective. Like, we will have less effective ablation in US if you were to use procainamide, in my opinion, based on this. So that would be, I think those three would be like the top three limitations. Again, like, it's a smaller trial, but again, the effectiveness was clear even in those 25 patients who underwent ablation. So I don't think that would be a big limitation, in my opinion.
Yeah, no, I agree. I just wanted to add, like, the other thing that wasn't very clear was it seemed like they didn't just go after an abnormal substrate in the outflow tract, that they also did PVC ablation if the PVC burden was high. And there's really actually very little information as to how a high PVC burden was defined and what it was that was actually ablated, and if those sites were still in the same place as the epicardial voltage mapping, and what percentage of the patients in either group had one, the other, or both.
Right.
Exactly. And I think those are actually key, along with the ablation strategy could potentially be key, and I think those details are a little less clear.
You did make a comment, though, that this is a more, extreme phenotype than we usually see. So I think that does give strength to this trial, that, we're talking about, a more active, phenotype, and they still had a nice response. So how far do you think we are from possibly having this compared to an ICD?
I think it's a great question, and that's what I would say. I've had that discussion with Dr. Nadamani before, because that's his goal, to get it as an ICD sparing.
Exactly.
I think some of the important things or interesting things that came out from this, as well as the BRAVE registry previously, when they combine all the patients with ablation, which they published as part of this paper as well, anybody who had a spontaneous type 1 Brugada pattern, where they were able to get rid of the Brugada pattern completely and at 3 months mark, and this is despite use of edge-milling, so not procainamide, edge-milling. None of those patients in follow-up had any events. Again, like severe phenotype, you get rid of Brugada pattern, then you don't need you don't have more VFib for next 4 years. So that's a very strong case, I feel like, as an ICD sparing therapy in a subset of symptomatic high-risk Brugada patients. But is it worth the risk in asymptomatic high risk or positive EP study types of patients? I don't know the answer to that.
Okay.
And I mean, if you look at the trial kind of as a globally, you still had 5 of 25 patients after ablation that had an event.
Yes.
Now, you could argue that most of those still had a substrate at the end of it, but is 20% your cutoff for not implanting an ICD, right?
Exactly.
That's a 1 in 5. So I think at the moment, I think this is, promising. We would love to see more and more details, and we'd also like to see it compared to quinidine.
Right.
Absolutely. And a little bit more details on the ablation strategy, but I don't know that we're completely willing to give up the ICD yet.
Great. I think those are sage words to end on. I'm Jason Jacobson for the Digital Education Committee, joined again by Marmar Vaseghi and Mayank Sardana. I really appreciate your time today.
Thank you for
Thank
having me.
you for paying attention to us.
Thank you.